Walking into a room and finding your patient suddenly disoriented is an immediate clinical crisis. Before it becomes a medical diagnostic puzzle, it is a physical emergency. A confused patient presents profound mechanical risks. In a hospital environment, they can fall out of bed, rip out life-saving IV lines, or walk right off the unit. The triage decisions you make next depend entirely on exactly when this confusion started. Identifying confusion triggers a physical lockdown. You secure their safety first, establishing a controlled environment before you begin investigating the medical cause. In neurology, confusion generally follows one of two timelines. There is the slow, steady decline measured in months and years. Then there is the sudden, sharp drop measured in hours. The slow path is dementia. Notice the physical tissue loss between the normal brain slice and the dementia brain slice. Because this is the permanent deterioration of the brain structure, nursing care focuses on long-term environmental management and reducing stimulation. Delirium is the sudden drop. This acute onset tells you the brain is temporarily compromised by an external factor. It is an active, time-sensitive emergency, and crucially, it is reversible. Mistaking a sudden, reversible crisis for a permanent structural decline means you miss the critical window to treat a severe underlying problem. This brings us to a major clinical pitfall: age bias. When an elderly patient suddenly becomes confused, clinicians often dangerously assume their baseline dementia is acting up. On exams and on the floor, reject the instinct to simply reorient the patient. Telling a delirious patient where they are does not fix why they forgot. Imagine a patient who is fully alert this morning suddenly trying to climb over their bed rails. Your job is to stop and investigate the physiological cause triggering the behavior. Test yourself right now. What are the 3 primary physiological causes of sudden delirium? You need to check for infection, particularly urinary tract infections. You review their medications for toxicity or adverse side effects, and you check for hypoxia, ensuring they have enough oxygen reaching the brain. When confusion hits suddenly, your primary task is relentless physiological investigation, not psychological reorientation. Let's put this together in practice. An elderly patient suddenly attempts to pull out their central line. You check their labs, and they have an active UTI. Your response requires 2 immediate actions. First, you secure their physical safety by supervising them and protecting that line. Second, you treat the physiological cause by hanging the prescribed IV antibiotics. Let's lock in the rules for your exams and floor practice. Mental confusion equals a physical safety risk. Sudden confusion means something is wrong right now. Always check for UTIs, medication issues, and low oxygen. Finally, treat the medical cause, not the confusion. Sudden confusion is a clinical siren. By treating the physiological problem, you clear the path for the mind to recover.